Hey guys, Woodruff here. So tonight we're going to talk about neurological disorders, specifically for the complex course. If you're an adult and watching this, do not spend your time watching this video. It's not going to be helpful to you right now. Trust me, you'll have time later to look at this if you really want to. But now's not the time. Do not confuse adult neurological and complex neurological. So out of all the sections for this unit that you're in for complex, neuro has the most components because under neuro we have spinal cord injury, we have seizures, we have traumatic brain injury, we have neurogenic shock, spinal shock. What else? Those are some little topics, but you know what I'm talking about. So, but I always say that there's the four main topics. So you have seizures, spinal cord injury, brain injury, and increased ICP. But within that, like I said, there's a lot of other little topics. There's some meds and stuff scattered through. So lots of stuff to go through. So I've created 10 questions for us to go through. And I'll try to talk about some other possible things you might want to study or look at too, just kind of knowing things we could cover on the exam. So keep in mind these practice questions are to help you to, better learn the information, but also focus on the strategy too, because at the end of the day, we can't know it all, but if we know our strategies, we can get a lot farther. All right. So first question. A nurse is assessing a client with a traumatic brain injury. Based on the findings below, what priority intervention should be included in the plan of care? So we first want to look at the client, so traumatic brain injury. And so that could be a variety of things, but they have something going on with their brain. So at least I know, they've had some sort of trauma. They could have a lot of stuff going on. I'm gonna stop there. So then, but based on the findings below, what priority interventions? This means what's most important. So all these answers could be right. And it says interventions, but it should say intervention. Sorry, it's not a select all that apply. It's just a singular. So do not mind my my poor spelling, not spelling, but I guess my poor grammar in this question. And please just take this as a non-select all that apply and what priority intervention should be included in the plan of care. So assessment findings. So I have to look at my assessment findings. So there's PERLA, which is the pupils are equal and round and reactive to light and accommodation. So that's normal. Okay. Glasgow Coma Scale of 6. That's a little bit on the lower end, so I don't love that. Then I have unable to assess orientation because they're nonverbal. So I have kind of a low level of consciousness, nonverbal patient. So it's saying what is priority for a nonverbal, low level of consciousness patient. So this requires me to have a little bit of information. It requires me to know a normal neurological assessment, which you'll definitely need to know. And you also need to know about your Glasgow Coma Scale, especially the trends, like what is high, what is low. You could be given a question where it gives you, like we did in adult, where it gives you assessment findings. You have to score their GCS. You could be given the GCS, and then really at this level, most of the time you're asked questions like, what are you going to do about this GCS? So that's kind of what this question's asking. GCS of 6, nonverbal, what is your priority? So A is focus your care on preventing complications of immobility. So, so that sounds like something important for an unconscious client, but is it like, top priority? Is it the main thing I need to do? I'm not sure, so I'm going to keep going. Next is focus your care on decreasing the CPP and increasing the ICP. So hold on a sec, let's back this up here. Focus your care on decreasing CPP. So CPP is the cerebral perfusion pressure. I think we want that high, not low. And it says, and increasing your ICP. And I think the ICP we want low, not high. So this is just testing to see if I know CPP and ICP. And by the way, I don't have any questions over it, but you'll definitely want to know how to calculate and figure out your CPP. So definitely know that equation, know how to calculate your MAP, know what a normal ICP is, 100%. I'm sure you'll see those numbers or be expected to calculate at least one question on your exam. I'm not guaranteeing. I will not give you money or gifts or compliments if I'm wrong. Needless to say, I don't think that's right. I think that's backwards. Focus your care on managing and maintaining a patent airway. I mean, this one I like the best so far because they have a low level of consciousness. They're not awake, or at least not verbal. And I can't tell necessarily just from a GCS of 6, but it doesn't seem like they would be awake. And if they're, usually there's the saying less than 8 intubate. And so you want to kind of consider that, like if they're at a 6 and they're nonverbal, I really want to make sure that their airway is staying open. And focus your care on decreasing pain and decreasing stimulation. Well, I like the decreasing stimulation, but this is probably one of those that I have to think about, are both answers correct? And I mean, of course, I don't want them to have a lot of pain or stimulation because what do you call it? That can increase their ICP and stuff like that. But when I think about ABC priorities based on these assessment findings, because I can't just look at traumatic brain injury, what's my priority? I have to think of traumatic brain injury that has a low level of consciousness and they're nonverbal. And, based on this information, I think the best answer here is focusing on a patent airway. So we have to think about our ABCs. So we are going to do other things to make sure that their ICP is decreased and that we're increasing their CPP, like decreasing their pain, decreasing stimulation. But ABCs always has to come first. And then after that, of course, if they're immobile, etc., we'll want to do things to prevent that. So question 2. A nurse is caring for a client with a closed head trauma. Which set of vital signs would require the most immediately? Okay, so this is going to be one of those PowerPoints where I just embarrass myself. But the thing is that like I've gotten to the point in life where I don't have a lot of shame because I've just done a lot of really stupid stuff and I tend to make a lot of spelling or other errors. But really what you should think about this, anytime you see a spelling error, is that I am probably sitting here very exhausted and overworked, and I'm doing my best, so please forgive me. And if you're one of those anal retentive English major kind of people, we don't have to be friends. It's okay. It's cool. So, it's all right. I appreciate myself for who I am and the effort that I make. So, needless to say, which set of vital signs would require the most immediate intervention? And I will say this. Always be able to laugh at yourself, make fun of yourself, because if you ever get to the point where you can't laugh at your own ridiculousness, what is life really about? So, all right, so this is a bunch of vital signs. So before we even jump into these answer choices, let's talk here about what do you call it? I'm kind of breaking down like a question like this, is that your brain, your mind can complete this, and like you can maybe see numbers wrong or read something wrong, like think it's giving you ICP instead of the respirations, or something like that. You can mix up some of these, so make sure you're reading correctly. And then also, I find it helpful on questions like this, like if I have scrap paper to put arrows or other things, to kind of talk about what's wrong. And so we're looking at the most immediate intervention, which means that this patient, like all these vitals might be reportable, but which one is going to lead to death the quickest? So first, I have increased heart rate, mildly elevated blood pressure, regular ICP, and regular respirations. So there's a lot of regular stuff in there. I mean, their blood pressure's a little high, heart rate's up a little bit, but not necessarily affecting any of their other stuff. So, I mean, so far, I'm not mad. So the next one has a heart rate of 102. And if you'll kind of notice, by the way, if you're looking at the answer choices, there's 2 high heart rates, 2 low heart rates, which tells me, I mean, eventually I'm going to be able to cross some of these out. So the next one is heart rate of 102, blood pressure 100/60 is a little on the low side. ICP is 8, okay? And the respirations are a little increased. So their blood pressure is a little low, their respirations are mildly increased, but I mean, their ICP is holding, they seem to be doing okay. Let's look at the next one. So there is heart rate of 52, so it's on the low side. Blood pressure is really high, and there's a lot of space between the top number and the bottom number for the blood pressure. I don't like that. ICP is still holding, but the respirations are only 10, which is abnormal. So the most things so far that are wrong, think of this almost like a risk factors question. The most things wrong so far for C. That doesn't necessarily mean it's the right answer, but I definitely want to take that into consideration. Last one, heart rate's low, blood pressure's low, ICP is more on the higher side, and respirations are normal. So really what this question's asking is it's seeing if I can identify Cushing's triad. So Cushing's triad is a sign of like herniation or really poor neurological function, or like I'm about to go to brain death. And the hallmark symptoms for that are low heart rate, a widened pulse pressure, which I'll explain what that means in a second, and irregular or decreased respirations. So for this question, the best answer is going to be C, based on that. Now, I know you might be saying, but oh, look, the ICP is higher in D and their blood pressure is low and blah, blah, but and maybe there is something I need to look into for that, but that's not a sign of they're about to be brain dead, whereas C is a sign they're about to be brain dead. And getting back to that widened pulse pressure, really that means that the top number and the bottom number are going to be spread apart from each other. So the top numbers like 190s, 200s, the bottom numbers usually less than 100. So there's a really wide gap between that. So low heart rate, widened pulse pressure, and then decreased or irregular respirations is one step before death. So the one I need to report or intervene the quickest on is going to be C. May need to intervene on the other ones too, but C is going to be my most deadly. So a nurse is caring for a client with increased ICP. Which intervention will be most helpful for this client? A, encourage the so real quick. So client with increased ICP, what's going to be most helpful? So really this is looking at, like, a lot of questions might ask this, what's going to be most helpful? So like, in other words, we're looking at what things are going to decrease an increase in their intracranial pressure or decrease, their increasing pressures in their brain. So A is encourage family to be at the bedside providing support to the client. Now, doesn't that just sound like so therapeutic? However, for neuro patients, a lot of stimulation, a lot of noise, stuff like that is not helpful. So I don't think this is going to be the best answer. B is have the client turn on their side and take slow, deep breaths. Slow, deep breaths sounds good, but I really have to think about, with increased ICP, what things are going to irritate, agitate the client. And is really turning on their side and taking slow, deep breaths going to make a difference? I like that they're maybe getting off some CO2 and stuff like that, but I'm doing some relaxation, but I don't know if all that stimulation is really going to be that helpful for them. Keep their airway clear with regular suctioning and respiratory treatments. Well, I know that suctioning sucks up all that O2, which we don't like, and it can cause a stimulation. I don't really see how respiratory treatments are going to help, so I don't like this one. You know what answer I'm looking for here is keep the head midline, turn the head of bed 30 degrees. Are you with me? Are you looking for that answer? Guess who purposefully didn't put that answer on here? Me. So yes. So anyway, but just so in case you're wondering, because here's the thing, is that maybe you'll get lucky and maybe that answer choice will be on your test, but it's actually really helpful to think about what are other good answers. Because sometimes professors specifically try to stay away from that hallmark answer that's like just an easy give me versus other things. So let's look at the last one. Preventing elevated body temperature and ensuring adequate oxygenation. So, I mean, I like adequate oxygenation. I know fevers can lead to increased ICP. So far, this is the one where both parts are correct. And I mean, it is something that can help. So backing up. So let's say that I was like, oh, I'm just not sure because it says most helpful. So let's cross out the things I know are not going to be helpful. So I know I don't want family at the bedside because that's too stimulating. And I know that I don't want suctioning. So I'm going to take off A and C. So then I'm like, have the client turn on their side and take slow, deep breaths, or preventing the elevated body temperature and ensuring adequate oxygenation. So out of these two, what's the less stimulating and the most helpful for ICP? I'm going to have to go with D because fevers increase your metabolism, which incredibly worsens your ICP. And then adequate oxygenation is so key for these patients. It's a vasoconstrictor, so it helps to counteract some of that vasodilation, but also if I have increased ICP, I'm usually low or have some sort of deficit. I'm healing from something when it comes to oxygenation. So I might need a little bit extra love. So, in other words, and the other strategy here is keep in mind, again, like I know sometimes, like some people, when they answer questions, they think, okay, what's the correct answer? And that can work sometimes. It's good to start thinking about it. But here's the thing is you can also get married to and you're looking. And so, for example, let's say that you were really set on, oh, it has to be something about position. You guys could have chosen B because you're like, oh, it has to be about position. And so you're choosing that one just because it fits best into what you think the answer should be. But sometimes you have to look, even if you don't like the answer and you're like, oh, I hate this answer. But if you know that it's the best answer there, sometimes you have to go with it. So next, a nurse is caring for a client with a basilar skull fracture. What priority assessments should be completed? So this one is a select all that applies. Priority assessments is correct. I think I've had 2 so far. no spelling or grammar errors. Woohoo! I still got something. So this is a select all that apply. They have a basilar skull fracture. And I'm not just looking at any assessments, I'm looking at priority ones. So the first choice is check the nose for drainage. Well, that seems pretty priority. I know that they can, I'm worried about CSF drainage. And so I do think I want to check their nose. Okay, so I'll check their nose for drainage. So check their ears for drainage. I think that's another place. I think that's called, what do they call it? A rhinorrhea and otorrhea. So both A and B so far, I mean, they sound good to me. C is assess lung and heart sounds. I mean, I think that you would do this for anybody, but I don't know if it's really necessarily going to tell me something life or death changing for a basilar skull fracture. It's not as, to me, it's an assessment, but not necessarily a priority one. D is assess for post-auricle bleeding. Oh, what a fancy word. Sorry, no. Assess for post-auricle bruising, excuse me. So I think post is behind and auricle is the ear. So behind the ear bruising. So, I mean, I know that they have that bruising around their eye. I think it's called raccoon eyes. And they have bruising somewhere else. I think it's somewhere around the ear. Was it the battle sign? So, I mean, that sounds right. That assess level of consciousness and orientation. So, what do you call it? That also sounds like something that's important. They've had a skull fracture, so they could have changes to their neurological system. So I would think that would be a priority. So far, I mean, I like everything but assess lung and heart sounds for priorities. I know some people might say, is it really priority to look for the bruising? Aren't we just expecting that? But it's still something that we want to keep an eye on and know what is present. We do want to know what hallmarks that they have of it and make sure, like, kind of trends where things are, if things are getting better or worse, etc. So we do want to look for presence of these things. So we're going to look for otorrhea, rhinorrhea, raccoon eyes, the battle sign. We're going to do a regular neurological assessment and then support things to help this patient recover. Watch for any additional issues, changes in level of consciousness, changes in labs, make sure there's no sort of bleeding, other stuff going on, no CSF leaks, and then support adequate blood flow to the brain. It's wonderful stuff. All right, question 5. We're halfway there. So a nurse is caring for a client with an epidural hematoma. Based on the most recent assessment findings, what is the priority action? So here we have a question. First, I have to know they have an epidural hematoma. There's subdural and there's epidurals. And I always remember epidurals need epi, or E for the epidurals, usually that it's emergency. So I'm already going to kind of frame in my brain, there probably is something going wrong here. So I need to see, especially because it's asking for priority action. So my assessment findings at 7 o'clock, my GCS was 10, my blood pressure was 110/76, and my heart rate was 105. Now, an hour later, my GCS went down to 7. Blood pressure is 95/60, so that dropped, and my heart rate went up a little bit to 112 from 105. So I'm showing signs of decreased level of consciousness, decreased blood pressure, and increased heart rate. So if I'm thinking I'm dealing with an epidural hematoma, my main concern here is hematoma, it's bleeding, and epidural hematomas are usually arterial bleeds. And so, like, right now, I'm worried about bleeding because they have a drop in blood pressure, increase in their heart rate, and a change in their level of consciousness. So really, let's start looking at the answers and we can kind of figure out what's next. So A is call the healthcare provider immediately. So, some of you might go to this one and go ahead and go to the next one because you're like, oh, I know this is emergency, just call the doctor. But I really want to teach you this strategy because this is going to be helpful for you. Anytime you see call the healthcare provider immediately, you always want to ask yourself, do I, one, have enough information to call the doctor? Is the information that I've already assessed, is it enough where I don't need to do any further assessments and that the doctor might ask about? Because I have to think about, okay, is there anything the doctor might ask about that they're going to want to or need more information? So in other words, if I'm going to call the doctor and I'm like, hey, patient had a change in, this status, are they going to be like, well, what's their this or what's their that? Like, if I have to think, kind of anticipate questions or information they might need. And I have to think about what information do they need to make a decision about what to do next. So is there any other information that I need from this kind of any other assessments? The second thing to consider is there any other interventions that I need to do that could save the patient's life or advance their care before I call the doctor. But there's always that fine balance. Am I doing something that's really going to advance their care and save their life, or is it just going to delay care if I don't just call the doctor? So I have to remember with epidural hematoma, is there anything I can do to fix this? Is there anything else I need to assess? So let's look at our other options. So one is recheck the blood pressure in 1 hour. So in other words, do nothing. And so, if I check in 1 hour, a lot can happen. They've already gone down 3 points in their GCS and their blood pressure has dropped, pretty significantly by 15 points systolic. And so that doesn't seem like a very helpful thing. And this seems like it's going to be emergency. So I'm going to cross out B. C is complete a full neurological assessment. So this goes back to my question, do they need more information? If I called a doctor and told them, hey, my GCS has gone down to a 7, my blood pressure is this, my heart rate is this, here's what the patient's admitted for, does that give them enough information, or do they need something else? Do they need to know pupils? Do they need to know other parts of the neurological assessment, muscle strength, etc.? So is there anything else that they need before they could make a decision about what needs to be done? And I'm not sure. I'm gonna keep going. The next one is, or the last one's prepare to administer blood products. So, it kind of, my brain goes there because they have a decrease in blood pressure, increased heart rate. So it looks like they're losing blood because they have the epidural hematoma. They may have an arterial bleed, but I have to think about, is doing that going to help fix the problem? Can I fix an epidural hematoma? So I would have to know for an epidural hematoma, there is nothing I can do as the nurse to fix that. Like I cannot go in and do anything to fix it. I could give them blood products, but they're just going to be bleeding it right back out. So I just have to figure out, do I need, so I'm going to say no to D. I'm either going to call or I'm going to finish up my assessment. So this is one of those times where I have to ask, is this enough information? Like based on the fact they have an epidural hematoma and they're showing signs of bleeding, decreased level of consciousness, is that enough for the doctor to know they need to come in and do a surgical intervention? And the answer is yes. Yes, that's enough information. Like, we're not going to sit there and be like, well, let's give it a little time and see if they get down to a 5 or if their blood pressure goes lower. If they're showing signs of active bleeding, the doctor should be coming in emergently to perform craniotomy and do a procedure, because that's really going to be the only fix here. Completing the rest of the neurological assessment is not going to change the fact that this patient is in need of an intervention. And I know some of you guys are probably thinking, but what if their pupils need to know? What if they're fixed or not? It's not going to change the fact they need to come in because they're showing signs of bleeding. They're showing signs of a neurological compromise. It's time to get going and get that bleeding fixed. Question 6, the nurse working on a neurological unit is preparing to care for a group of clients. Which client should the nurse see first? So you guys hate these questions because it actually requires you to usually it has like 4 different patients that you need to know about. But we love as instructors these questions because it really tests your knowledge over multiple clients. So we need to look at what their diagnosis is and then what is going on that we need to do for them to prioritize these. So the first option is a client with a spinal cord injury requesting their PRN or as needed hydrocodone. So patients in pain with a spinal cord injury. Now we know we hate to say this, but pain is usually low priority. So far I'm no red flags or, going off in my head. Let's kind of wait and see. Client with a traumatic brain injury who's due for their mannitol. So, that's a little bit higher. Mannitol helps to decrease intracranial pressure. That's kind of higher up on my list. So I'm kind of leaning more towards that one. What do you call it? So far out of the 2 that I've looked at. A client with a seizure disorder who had a seizure 2 days ago. So, they didn't just have a seizure. They're not in the post-ictal phase. There's no like immediate need. There's no med that's due, something like that. Like if they were due for their scheduled, anti-seizure dose, maybe be a little bit more key because we really want them to take that in a timely manner. But so far, like no, red flags or anything are going off. A client with a subdural hematoma whose morning hemoglobin is 9.5 grams per deciliter. So subdural, those are usually like those venous bleeds where they're not as, as serious. Usually they can resolve and absorb on their own. Their hemoglobin is 9.5. So it's abnormal, but not necessarily low enough where I'm going to give anything and kind of expected for a client who has a brain bleed. So far I have, a client who's requesting PRN hydrocodone. I'm going to go ahead and say no. And a client with a seizure disorder who had a seizure 2 days ago. Nothing immediate's really going on there. So I'm down to B and D. So do I need, and this is another one of those kill factor questions where you want to go and look and say, like, which of these patients, if I don't see, could die from this. So if I don't see a patient who is, if I don't go and give their mannitol, they could have increased intracranial pressure and possibly, what do you call them, have, brain death, herniation, etc. Depending, I know that's extreme, but it's possible. Whereas a client with a subdural hematoma, morning hemoglobin 9.5, most likely there's no intervention or anything I'm going to need to do there. So more than likely, if this was me, and I was putting this in order, I would probably see B first. I would go give the pain medication to the patient that is one of the hydrocodone. And when it comes, the seizure disorder client has nothing going on, I would probably go see the subdural hematoma patient next. Just make sure there are no changes to the neurological assessment. And then last but not least, see that seizure disorder patient. So yes, so the correct answer here, because I know this wasn't an ordering question. If you were like, where'd that crazy lady come from? This isn't an ordering question. I just like to make things spicy. So the correct answer here is going to be B, a traumatic brain injury who is due for their mannitol. And just so you know, so you do want to know, the meds for neuro stuff, you're going to want to know about steroids, mannitol. Instead of mannitol, we can also use hypertonic saline or 3% saline. So I definitely look over those because you could have questions about them. I know that you're probably saying, well, why didn't you make a question about them? There's too many topics in neuro and not enough time. So yes. So question 7. A nurse is preparing to discharge a client with a seizure disorder who is prescribed Phenytoin, also known as Dilantin. What teaching point should be included for this client? Select all that apply. So, so this is a med question. This is a med teaching question. So this is a chronic medication that a patient would be on. It long-term helps to reduce seizures. This, Phenytoin is not for acute seizures. They may start loading someone up with it after having an acute seizure, but the only medications that treat acute seizures, which you will want to know about, are your benzodiazepines like lorazepam. So yes, also known as Ativan. Take a ride on the van. So anyway, but back to Phenytoin. So I'm looking for teaching points. So A is never stop this medication suddenly. Well, I think that's for every medication, but I think if you're taking a medication that's going to stop you from having seizures and then you stop it, that sounds really risky. So I'm going to say that should be included. B is this medication can make you feel drowsy. So I'm pretty sure, I feel like all of these meds, because they depress how your brain is firing, I feel like that would make sense. I think that they, that crazy Mrs. Woodruff said something about them causing the, what is it? Dizzy, drowsy, and drained, maybe? Dizzy, drowsy, drained. I feel like there's a different D. Dizzy, drowsy, maybe there's something else. But anyway, but maybe I can think Dilantin makes you dizzy and drowsy. So most seizure meds in general are going to make you dizzy and drowsy. So kind of keep that in mind. Probably don't want them to be doing any activities that are going to require a lot of alertness, etc. So yeah, I'm not going to go too much deeper into that, but as a whole, that seems to make sense. I think I would teach that. You will need regular kidney function monitoring. So with Phenytoin, I remember something about the liver. I don't remember anything about the kidneys. So, everyone, needs their kidneys checked every now and again, but I don't really think there's any connection between Phenytoin and kidney function. So I'm going to say no. Make sure to be brushing your teeth daily. Well, isn't everybody? So yes. So we have to think about those as specific to Phenytoin. And I feel like there's a side effect of it that involves the teeth. It's something about the gums getting really big. What's that called? It's that gingival hyperplasia. So you want to kind of keep it in mind that, the intervention, brushing their teeth daily, is going to help keep things clean and help to decrease their risk of having gingival hyperplasia. So I would say that is specific. So E is you will need blood draws to assess therapeutic levels. So I have to remember, is this one that can be toxic? And I believe it is. I think it has therapeutic levels that have to be monitored on a regular basis. So I'm going to say yes to that one. Now, if I was a student, and if you can tell, I do play the student sometimes. So sometimes I really am thinking of things. I'm like, what is that? But I did know about gingival hyperplasia. I just like to give y'all time to process things, but also not feel bad because there's sometimes things that don't come to my mind too. And keep in mind, I've taught this over and over and over again. These aren't my best subjects. Like, well, neuro, I'm okay on because I see a lot of neuro patients in my job, but eventually, here soon, it's not going to be tonight. I'm going to get in, by the time you watch this, this may be in the future. So you're talking to past me. It probably will be posted. But if you're watching this tonight on October 27th of 2022, I will not have posted the autoimmune practice questions yet. I will be getting to those, and that is not my best subject, but I do the best I can with what I'm given. So just know, like, I mean, as a teacher, of course, like the repetition, teaching this over and over and over again, you start to learn some things. So if you're one of those students who just feels like, oh, I'm never retaining, I'm never holding on to things, once you're in a place where you're working and you're giving the same meds every day, you're giving this, taking care of the same kind of patients, stuff kind of comes to you naturally, and you start to become an expert in your field. But it's going to come with time and experience, not even from doing a million practice questions. So you're going to have, it's what's called post-NCLEX amnesia. After you take your NCLEX, it's like everything you learn in nursing school leaves your brain. You won't believe it. It's a crazy magic trick. Needless to say, back to the question. So so far it's, I was going to talk about strategy. So we chose A, B, D, and E. Now, some people would go and be like, oh, it can't be all four. You know, they're going to be looking for one other one to let go. Do not play games. Once you've done true or false, gone straight down this select all that apply, do not play games. Go ahead and go with your gut and move forward to the next question. Do not try to play games. Is it too much? Is it not enough? Etc. Question 8. A nurse is carrying orange spinal cords, T4 spinal cord injury. Upon assessment, the nurse finds the client to be extremely diaphoretic and is complaining of a pounding headache. What is the priority intervention? So there's a couple things to keep in mind here. You know, with spinal cord, they can have acute problems like spinal shock. They can have neurogenic shock. They can have autonomic dysreflexia. They can have aspiration, airway issues. There's a lot of acute stuff that can go on. Then there's more of the chronic stuff, bowel bladder. They can also have complications of immobility, a lot of the PT and other stuff. There's long-term teaching. There's the psychological, sexual dysfunction, a lot of long-term stuff. Don't just, I know a lot of times in complex, you want to study those acute things. And so a lot of times people get really hung up and they study the ICP so well, they study the acute spinal cord stuff that they forget to. I was like, study the chronic spinal cord stuff or what can happen later. So this is an acute question, but don't forget to study the teaching and the long-term management of spinal cord injuries too. Friendly note from your neighborhood professor. So I have to first figure out what's going on here. So they're extremely diaphoretic and complaining of a pounding headache. That's all I have. I don't have any information. I need to figure out what to do next. So my option 1 is to get a set of vital signs on the patient. Well, I should say client. It's so good. I can't be perfect. I got to let it go. I could get a set of vital signs, you know, I like that answer. I just don't know if it's going to be the first thing I need to do. I have to say, is there anything I could do before doing that could help affect their condition immediately? Then there's insert an IV and prepare to administer fluids. So, I mean, they're diaphoretic and have a pounding headache, so that would make me feel like they might need fluids, but I don't know what's going on yet. So, you know, let's keep going. I might need to do further assessments. Next says assess abdomen for distension and bowel sounds. So this is saying is there something in their abdomen going on? Now, I don't remember any acute abdomen issues or why their abdomen would be distended or a problem with their bowel sounds. So I'm not going to go, I don't think it's going to be C. So, you know, so far, you know, I'm between A and B. The last one is increase the head of the bed to 60 to 90 degrees. So position changes can affect blood pressure, but then I have to kind of decide here, you know, okay, so I'm between A, B, and D. So let's say, you know, we always talk about being down to 2. What if you're down to 3? So I have to think about here, just based on the fact that they're extremely diaphoretic and complaining of a pounding headache, do I automatically know that they need IV fluids? Now, like, I don't even know what their blood pressure is. I don't know what else is going on. And I don't know any emergencies for spinal cord that require fluid administration. I know y'all are thinking shock, but don't worry, we'll talk about it. So I'm down to A and D. So I check their vital signs first, or do I sit them up first? First, I have to think about what can I do quickest that can have a substantial effect. Just because something's quick doesn't mean I need to do it first. But sometimes I have to think about, okay, which is going to have the most direct or helpful effect. So if I know what's going on here, extremely diaphoretic, pounding headache, these are the hallmark signs of autonomic dysreflexia. So this happens for people that have T6 and above injuries, and it's this unopposed, really intense pressure below the level of their injury, which leads them to try to compensate in their upper half of their body, but they can't compensate because their spinal cord is torn, so that they can't send the signals to the rest of the body to chill out. And it's related to too much pressure in one, either from their belt's too tight, their SCDs or TED hose are too tight, their bladder's full, their bowel's full, their skin is irritated. So I have to ask myself, do I need to get vital signs, or do I need to check increase the head of the bed? And so increasing the head of the bed will decrease their blood pressure, which is not in here because we haven't checked vitals yet. But based on these assessment findings, most likely their blood pressure is super high. I can start to decrease their pressure by increasing the head of the bed. So that seems, as I'm trying to die, that seems like the best answer to me, is increasing the head of the bed. Now, I know some of you are going to say, but we don't know that their blood pressure is high. Let's check it first. But here's the thing, is that you have to think, is raising their head of the bed 60 to 90 degrees based on our assessment findings that we pretty sure it's autonomic dysreflexia. Is that ever going to cause harm, even if their blood pressure wasn't elevated? No, it's not. And it can start to relieve some of the pressure that's going on, some of that unopposed pressure. And so we can get a set of vital signs and confirm, yes, their blood pressure is high, just like we thought, or we can go ahead and start taking action. So usually the priority actions for autonomic dysreflexia is sit them up. After we sit them up, then we want to find the cause of the irritation, or find the cause of the pressure, whatever the pressure is, bowel, bladder, clothing, skin, whatever it might be. Remove that stimulus, take care of that stimulus, and move from there. So keep in mind, the problem is not their vital signs, because I can sit there and look at their vital signs and say, yeah, there's a problem here. It's going to maybe give me some information. Yes, I'm going to need to get it, but it's not actually going to help treat the problem. So D allows me to start taking action now that could definitely help to start moving in the right direction for this patient. Question 9, don't worry, we're almost there. Nurse is caring for a client with an acute C4 spinal cord injury and neurogenic shock. Based on the assessment findings below, what is the first action the nurse should take? So we've got a blood pressure of 90/65. Oh, sorry, real quick. So C4. So I always like to, when it's spinal cord, I always like to think about like how high up. So we're talking about a high level injury. And so I always remember C, if they can breathe, when they have C level injuries. And not just any spinal cord injury, they're in neurogenic shock. So there's spinal shock and neurogenic shock. I'll talk about this, but this is neurogenic shock. So this is a blood vessel issue. Based on the assessment findings below, what is the first action the nurse should take? So let's see here. So their blood pressure is 90/65. It's low, expected neurogenic shock. Might need to do something about that. Heart rate 52, low. Probably need to do something about that. Respiratory rate 18, so that's normal. So they're not necessarily having like a breathing pattern issue, at least not at this moment. SpO2 96, seems they're doing okay, and temperature 97.3. So that's on the low end of normal, but not earth shattering or incredibly low, like towards death or hypothermia. So let's look at our options here. So first, do I need to apply oxygen via nasal cannula? So, I mean, a lot of people might say, oh, it's a C4 injury. That's got to be it. And they're in shock. But I mean, because yes, oxygen and shock, usually that's going to be one of the first interventions. We have to look here, based on these assessment findings, are they showing a sign of an oxygen problem? They're not at this point. It might be the best option, but let me look if there's anything that's better. Apply a warm blanket to the client. So their temperature is low. Applying a warm blanket, may help this client to improve their temperature. But I don't necessarily think that like rewarming is the first thing, or like warming them up, like they're at 97.3 and getting them up to 98 is going to change the fact that they're in shock. It's not like an ABC priority necessarily to me. Administer atropine per order. I can talk order. And so I have to remember what atropine is. So atropine is a medication that I remember TROP, and atropine, it triples the rate of the pulse. Now, it doesn't officially actually triple it, but I just think of it, it's going to increase my pulse. My heart rate's low. That seems like it would help. If I have a higher heart rate, I can have better cardiac output. Then administering IV fluids per order. So their blood pressure is low, so it sounds like it'd be good. So I would probably get down to between C and D. So what's most important is these are both circulation things too, increasing my heart rate or administering fluids. So to answer this question correctly, I would have to have knowledge of neurogenic shock and know that this is a vasodilation type of shock, and fluids are not usually super helpful with these patients. We don't want to get crazy with the fluids because it's not that they're missing fluid like in septic shock and stuff like that, where we really want to like load them up with fluids. And neurogenic shock, the fluid is just in the wrong places. They're vasodilated. So we don't really focus on IV fluid. We use it really cautiously in neurogenic shock because they can get overloaded. So most of the time with neurogenic shock, we're focused on getting their heart rate up. We a lot of times use vasopressors and stuff to help with some of that vasodilation. We help with their temperature and just maintain circulation, perfusion, oxygenation. So based on that information, the best answer here is got to be C. Administer that atropine. Let's get that cardiac output up and get them doing better. Last but not least, a client is recovering from a T9 spinal cord injury. Which teaching should the nurse provide this client regarding their recovery? So T9, so it's a thoracic injury and it's not super high up. It's actually a little bit lower. So that's, give me some hope. So this is more of a long-term question. Which teaching should I provide regarding their recovery? Sorry, getting to the point where I've made too many of these today and taught today and had enrichment today. So my voice is getting a little lost. I'm getting that myasthenia gravis like I was talking about. Or was that what I was talking about? Yeah, maybe so. I think that was what I was joking about today on enrichment. But anyway, needless to say, you want to look at, you want to look at, for this one, the thing you want to consider is what level of injury they're at. Because there's going to, I don't want to say sure because I'm never sure of anything, but I am pretty sure that you will have some question on your exam that's going to give you a spinal cord injury level. And you're going to have to say, what does that mean? So in other words, you need to know if it's a cervical injury, what are you going to expect in that patient? What should they expect for recovery? If it's thoracic, based on different levels of thoracic injury, what are your biggest concerns? What teaching do they need? So for T9, let's look at kind of what some of our options are here and which one's most appropriate. So A says you may need help with activities that require use of your upper extremities, such as teeth brushing. Well, that one doesn't seem to be appropriate because that seems like, T9, they probably are paraplegic and they should have use of their arms. They could be independent in a wheelchair. So I would think no for A. I don't think that I'm going to provide that. You may need assistance with bowel and bladder training as you may have retention or incontinence. Now, the lower we get, the more we have bowel and bladder issues, or like that's more of the focus. So I like that one so far, but let me keep looking and see what else there is. You may need to have respiratory treatments at home due to weakened neck and facial muscles. So I know that, all spinal cord injuries can have weakened muscles like intercostal muscles, other respiratory muscles, but I don't like the end of this question because it says weakened neck and facial muscles. In T9, they really shouldn't have any weakened neck and facial muscles from that low of an injury. So I don't like the full answer. So I'm going to say no to that one. D is you're at high risk for autonomic dysreflexia and need to learn how to prevent and manage this complication. So I would have to know that autonomic dysreflexia only happens to T6 and above. So this patient's a T9, so they would not be at risk for autonomic dysreflexia. So with that information, that only leads answer choice B for me to, be able to to really be able to get the information and stuff that this patient needs based on their injury. So you definitely want to know your spinal cord levels and what you're going to see mobility wise, what kind of functions, what rehab potential, and other things they're going to have at different levels. But anyway, that is the 10th question. So hopefully you enjoyed this neurological storm of emotions and other fun things. I know there's a lot in neuro, but definitely take the time to break down and differentiate those 4 parts of neuro: seizures, spinal cord injury, traumatic brain injury, and increasing ICP. Know some of your meds, know your CPP, how to calculate it. Know chronic versus long-term spinal cord, know your seizure meds, and know general seizure treatment and differentiating types of seizures. You guys are going to do great. I have full faith in you. See you next time.